all the settings are clear for you? Yeah.
Should I share my screen now?
Yeah, sure. Please go ahead.
Is it visible?
Well, yes, you could do it in the full screen mode, your
Yes.
presentation. Yeah, well, that's good. Yeah.
Shall I start now?
Yes, sure, Dr. Ritika.
Okay. So good morning to all. And I would like to first thank you for the organizers to arrange such a wonderful conference in this difficult COVID time when we are not able to meet, but this is a virtual platform. So we are able to meet with different pathologists from all over the globe. And this is quite a different, but a new thing for all of us. And brief introduction about myself. I am Dr. Ritika Sharma and I did my post-graduation in pathology from India. And currently I am working in UK since simultaneously preparing for my Royal College exams. So thank you for giving me this wonderful opportunity to speak about a small study which I did during my post-graduation. And it would be great to discuss about my study among the eminent pathologists from all over the globe. I'll be discussing some of the salient features of my study. Please feel free to give your suggestions or ask questions. Now, the topic of my study was comparison of autofluorescence technique with other conventional methods in detection of mycobacterial bacilli on fine needle aspiration cytology in cases of tubercular lymphadenitis. I know the topic is quite huge, but the main gist of my topic is about tuberculosis. So, as we all know, and I think everybody will agree with me that tuberculosis is one of the oldest disease known to mankind, and its evidence is detected even in Egyptian mummies. So it's quite oldest disease, and it remains as a leading cause of death worldwide, especially if we talk about the developing countries like India. Tuberculosis remains a major global health problem. Though we have reached a new millennium, but at the dawn of this new millennium, we are still mute to witness the silent yet efficient march of this serious disease, its myriad manifestations, and above all, its unequaled, vicious killing power. Throughout the millennia, tuberculosis has never ever disappeared from the developing world. Though the Western countries, they have been able to have control over this deadly disease, but if we talk about the developing countries, they are still in phase of curing this disease. So, a brief introduction. In the initial part of 20th century, one of the great pathologists has rightly said that as a destroyer of mankind, tuberculosis has no equals. Tuberculosis ranks as the second leading cause of death from an infectious disease worldwide after the human immunodeficiency virus. If we talk about India, where I did my study, India accounts for 1/5 of the world's new tubercular cases and 2/3 of the cases in Southeast Asia, which is a huge number. If we talk about the world, almost 1/3 of the world population is infected with tuberculosis. And in 1993, WHO, they have declared tuberculosis as a global emergency. It remains the single most infectious disease causing the highest mortality in humans, leading to 3 million deaths annually and about 5 deaths every minute, which is quite a serious thing. If we come on to the most common presentation, we all know the pulmonary tuberculosis is the most common presentation. But it does not mean that it presents only in this form. The extrapulmonary tuberculosis constitutes about 15 to 20% of all cases of tuberculosis. And out of these extrapulmonary manifestations, lymphadenopathy is the most common. Now comes the challenges which pathologists and clinicians have to face in diagnosis of these lymphadenopathy. So one way was to just excise the lymph node and send it for the diagnosis. But we'll all agree that it's quite invasive and not everybody will be happy in going to these invasive techniques. So this has been overcome by the technique called fine needle aspiration cytology, which has an important role in the evaluation of peripheral lymphadenopathy as a non-invasive alternative to excisional biopsy. Now, let me ask you, so who are at risk of tuberculosis? So everybody here will agree with me that anybody and everybody can be at risk of tuberculosis. It is such a deadly disease, it is such an infectious disease that anybody can get this infection. The list is quite exhaustive, but just to name a few high risk categories, these include the close contacts, means those who are sharing the same household or other enclosed environment of persons known or suspected to have tuberculosis, persons who are infected with human immunodeficiency virus, because those who are having this virus, they are already immunocompromised and have increased risk of contacting tuberculosis. Other high-risk group include those who inject these illicit drugs or other locally identified high-risk substance users, such as cocaine users, healthcare workers like us, and the clinicians who look after high-risk patients, foreign-born persons, including children, recently arrived from countries that have a high incidence or prevalence of tuberculosis. Now, after discussing about the risk factors or the groups who are at increased risk of tuberculosis, now I would like to discuss briefly about the etiology of tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis. Now the genus Mycobacterium is included in the family Mycobacteriaceae and the order Actinomycetes. Now this genus consists of non-motile, non-spore-forming aerobic bacilli. They are slightly curved roots showing filamentous branching forms and beading. Now, the special characteristic about this Mycobacterium tuberculosis bacteria is its unusual cell wall structure. When I'm saying that it's unusual cell wall, I want to say that the cell wall of this bacteria contains N-glycosylmuramic acid in lieu of N-acetylmuramic acid and has a very high lipid content. And because of this reason, it is difficult to stain this bacteria with commonly used basic aniline dyes, which we normally use in our lab. Because of its unusual cell wall, high lipid content, this bacteria, it resists decolorization by acidified alcohol after prolonged application of basic fuchsin dye or with heating of this dye. So here comes the challenge that we need to have special stains for this bacteria in order to identify them and make an appropriate diagnosis of tubercular lymphadenitis. Now, as I told you that lymphadenopathy is the most common extrapulmonary manifestation, and for this identification of lymphadenopathy, fine needle aspiration cytology has assumed an important role in its evaluation. Now, diagnosis is mainly based on clinical features, cytomorphological patterns, histopathology, identification of acid-fast bacilli, and isolation of Mycobacterium tuberculosis on culture media. Now, there are various cytological patterns which we can see in the Mycobacterium. So this includes the epithelioid granuloma with necrosis, which means that when we see aspirate and when we stain it and when we see the cytomorphological features, we can have epithelioid granulomas along with necrosis. So in this first picture, I'm sorry for the not so good quality of my pictures, but I'll try to show what I want to show. So basically, the first picture that's showing is FNAC smear revealing the necrotic background, and in amongst this necrotic background, we can see the lymphocytes, lymphoid cells, and epithelioid cells. The down picture, there are only few lymphocytes and the background is necrotic. Now, the third picture, it shows that cluster of epithelioid cells forming granuloma, which we can see in the another picture, which is the epithelioid cells. They are slightly elongated and different from the round lymphocytes. So as I told you that the cytomorphological patterns of mycobacterial infection can be first epithelioid granuloma with necrosis. So this is the necrotic pattern which I showed. And in the next picture, we can just see that there is a multinucleate giant cell in the background of lymphoid cells. If we see the high power of this picture, then these epithelioid cells, we can just see how elongated they are and how bigger in size they are as compared to the lymphocytes. Another picture showing the cluster of epithelioid cells forming granuloma. So these are typical elongated slipper-shaped epithelioid cells in the background of small lymphocytes. Here's the another picture showing the granuloma. So the first pattern is epithelioid granuloma with necrosis. Another pattern can be, we can just have the granuloma, epithelioid cells forming granuloma without any necrosis. Like in this picture, we can't see any necrosis. Similarly, in this picture, the necrotic pattern is not so prominent. And the third pattern is necrotic material without epithelioid granuloma, which is shown in this. There is necrotic background, but we are not able to appreciate any epithelioid granuloma. And the fourth pattern is necrotic material with neutrophils without any epithelioid granuloma. Means there is necrosis, there are inflammatory cells, along with lymphocytes, there are neutrophils, but there is no epithelioid granuloma. Now, for the detection of these acid-fast bacilli, we have some conventional methods, which we all know. These are Ziehl-Neelsen staining and the cultivation on Lowenstein-Jensen media. But there are certain other methods besides these conventional methods, which include the fluorochrome staining pattern, there are two types of staining which comes under this fluorescent staining. This is auramine rhodamine stain and autofluorescence on PEP stain. Now, other methods of identification which are performed by the microbiology department include serological method, in which we detect antibodies against the mycobacterial antigen. Then chromatographic methods like thin layer chromatography, gas liquid chromatography, and high performance liquid chromatography. Then the newer methods, molecular methods like DNA hybridization and DNA microarrays, nucleic acid amplification methods like polymerase chain reaction, and the DNA gene expert is also a new method of identification which was introduced in last few years. Now, after this brief introduction about tuberculosis, its etiology, about the bacteria, now I'll be discussing about my study, which I did. So the main aims and objectives of my study was to study the detection of mycobacteria in lymph node aspirates on autofluorescence and comparison of autofluorescence and other fluorescence staining techniques with conventional methods like Zinn-Nielsen staining and culture. Now, this study was conducted in the Department of Pathology, Pandit B.D. Sharma, PGIMS Rohtak, where I did my post-graduation over a period of 2 years. Now, the study group constituted aspirates from 75 patients of tubercular lymphadenitis or suspicious of tuberculosis. So, informed consent, written consent of all the patient was taken for performing different diagnostic tests. Now, a performa was prepared, and this performa included the relevant information about patients, including their age, gender, duration of disease, systemic symptoms, or what we call as constitutional symptoms of tuberculosis, such as fever, chills, night sweats, and weight loss. Also included in the performa was the significant patient medical history, including history of any malignancy, carcinoma, lymphoma, infections like AIDS, and past history of tuberculosis or contact with tubercular patients. After taking this detailed history and the written consent of the patient, the physical examination of lymph nodes was done, and it was reported, including the size of lymph nodes, the site of lymph nodes, consistency, whether the lymph nodes are tender or non-tender, whether they are discrete, matted, or fixed, in order to just differentiate and to find out at the end of the study that is there any particular pattern of lymph nodes which we can see in tubercular patients, or they can have a wide variations. Now, after physical examination of the lymph nodes, the patient blood sample was taken for routine investigations like hemogram, complete blood picture, ESR, that is erythrocyte sedimentation rate, MON2 test, and chest radiogram. Now, what was the inclusion criteria and exclusion criteria for my study? So, in my study, all males and females of all ages who were suspected of tuberculous lymphadenitis were included, while the patients who were having some malignant conditions or the history or the radiographic imaging were suggestive of some primary metastatic malignancy, they were not included in our study. and also those who in which the sample FNAC sample was inadequate were excluded. Now, fine needle aspirations were performed under a sterile aseptic conditions on the suspected lymph nodes using a sterile disposable 23 gauge needles and 20 cc syringes. Now, 4 smears were made from each aspirate. 3 were air-dried smears, and they were stained with Jamesa or Leishman, Ziehl-Neelsen stain, and Oramin-Rhodamin stain. And one smear was wet fixed for Papanicolaou staining for autofluorescence. The aspirate was also sent to the Department of Microbiology for culture on Lowenstein-Janssen medium. Now, observations which we found on different staining pattern. On Ziehl-Neelsen staining, the smears which were stained by Ziehl-Neelsen method were observed under oil immersion field using light microscopy, and AFP appeared as pink, slightly curved rods 2 to 8 micrometer in diameter against blue background. So this is the acid-fast bacilli, which is we can see as pink beaded filamentous bacilli on Ziehl-Neelsen staining. On Oramin-Rhodamin staining, which is a fluorescent stain, the smears stained by this method were observed with low power magnification using fluorescent microscopy. And acid-fast bacilli, they appeared as bright yellow or golden yellow against a dark background. So these were these bacilli. The background was dark, and these small curved bacilli were seen on Oramin-Rhodamin staining. On autofluorescence staining, the smears which were stained by Papanicolaou stain, that is the PAP stain, were observed with low power magnification using fluorescent microscopy, and AFP acid-fast bacilli, they appeared as brilliant yellow fluorescent rods, thin and slightly curved, with a uniform length of 2 to 2.7 microns. So there are lots of fluorescent things in this field, but I have taken this picture just to show you that not only the Mycobacterium bacilli fluoresces, there are other things which are known as artifacts. They also fluoresce. But how to differentiate between whether this is acid-fast bacilli or these are the artifacts? So the acid-fast bacilli, these are the small curved ones, and the artifacts, they are the straight shining things. So the finding, as we all know that while detecting the acid-fast bacilli on Ziehl-Neelsen staining, we need to see them under oil immersion, and it's quite a tedious task to identify them. But the only advantage with the Oramin-Rhodamin and the autofluorescence staining was that the smears were observed with low power magnification. There was no requirement of oil immersion to visualize these bacteria on these staining methods. The culture was the aspirate was sent to the microbiology department, and on Lowenstein-Janssen media, Mycobacterium, they appears as brown granular colonies called buff, rough, and tough. So this was the culture which we performed in the microbiology lab. This is a negative control with no growth, and these are the pictures which are showing this growth on the Lowenstein-Janssen media. These are the brown granular colonies of Mycobacterium bacilli. Now, taking culture positivity because the culture is considered to be the gold standard for the detection of mycobacterial bacilli. So taking culture positivity as standard, sensitivity and specificity of different assay methods were calculated. The results were analyzed by using the chi-square test, and p-values were evaluated at the 5% level of significance. This picture, we can see the positive MON2 test, which we perform when the patient, first of all, when the patient comes to the clinician with who is suspicious of tuberculosis, then the first thing which is done is the MON2 test. So what we do in the MON2 test, a specified dose of tuberculin antigen is injected into the patient's arm. And if there is a response to that tuberculin antigen in the form of this induration, that means that the patient is having Mycobacterium tuberculosis. Now, some of the salient features which I found in my study, and I found them quite relevant because there are certain things which we think that it is fixed related to tuberculosis, but that's not the case. Mycobacterium tuberculosis causing tuberculosis infection, presenting in different ways and causing the different manifestations which we even did not think about when before I performed this study. So first of all, my first picture shows how the cases were distributed according to age. So in my study, it was found that the maximum cases, that is 32%, were in the age group of 30 to 50 years, followed by 28% in the age group of 20 to 30 years, and 21% in the age group of 10 to 20 years. However, if we see, the youngest patient in our study, in my study, was around 1.5 years of age, and the oldest was 70 years. So it was found in my study, as well as other studies in the literature which have been performed, that tubercular lymphadenitis can affect people of any age, ranging from children, small children, to adults. Our study, my study showed slight late age predisposition. Now, the reason could be attributed by the attendance pattern of the sick patient to the hospital, late presentation of the extrapulmonary symptoms of tubercular lymphadenitis, or maybe just due to low sample size, people from this age group form the representative population and may not represent the whole population. But the main finding which I found from this study was that there is no age group which is spared from tubercular infection. Now, distribution of cases according to the gender showed that female predisposition was seen more in my study, with around 57% patients, female patients affected with tuberculous lymphadenitis, as compared to around 42% male patients. The reason for female outnumbering males could be due to difference in the number of patients included in the study and the geographical distribution. Now, as I told you that when I started my study, and a performer was prepared in which we took history of the constitutional symptoms like night sweats, fever, cough from the patients who presented with this tuberculous lymphadenitis. So strikingly, the thing we realized that around 70% patients, they presented without any constitutional symptoms. Now, the most common reason that tuberculous lymphadenitis may go unrecognized for a longer time because there is absence of constitutional symptoms. And this is quite challenging because if these constitutional symptoms are present, then they ask patient that to go to hospital and to get themselves checked. But if the symptoms are not there, so patients are not able to understand that they are having some disease for which they need treatment. So this is quite a thing which we should consider, that it doesn't mean that if the patient is not having the typical constitutional symptoms of tuberculosis, then these lymphadenitis cannot be due to tuberculosis. This can be due to tuberculosis because tuberculosis can present without these constitutional symptoms. Also, what I realized from my study was that they might be due to the increased awareness of the people that they come to the hospital as soon as they notice some swelling and do not wait for these symptoms to appear. And this is a good thing because if there is early diagnosis, then the treatment can be started early and that is beneficial for the patients. Now, most of the cases from our study had positive family history or history of contact with tuberculosis patients. As you can see, the 70% of the patients, there was positive history of contact with tuberculosis patients. This could be attributed to high rates of transmission in tuberculosis, thus making person living in vicinity of tuberculosis patient more susceptible to contract the infection and develop the disease. Now, coming to the site of lymphadenopathy, in concordance with most of the studies done on tuberculosis lymphadenitis, even our study showed the highest involvement of cervical lymph nodes, followed by supraclavicular and submandibular. Now, the reason for the highest uh, involvement of the cervical lymph nodes is because the cervical lymph nodes, they are the first to be drained lymph nodes. Now, a common misconception or understanding from the past which we have is that the tuberculous lymph nodes, they present as in a matted form, but it was not so, which I found in my study. In almost 65% cases, they presented with discrete lymph nodes and not the matted one. Now, when we perform this ESR on the patients with tuberculosis lymphadenopathy, so almost all the patients, they have this high ESR level, which indicates that the ESR level is raised in chronic infections like tuberculosis. Now, we also took a sputum sample from the patients who were suspicious to find out the AFB positivity in the sputum. And the strikingly, almost equal, 48% were showed positive sputum for AFB, and 45% they were negative. So that means that the sputum positivity is there when the patient is having pulmonary tuberculosis. So might be the negative patients were those who were not having the symptoms of pulmonary tuberculosis, or the acid fast bacilli level was so low that it could not be detected. Now, as I showed you the picture of MON2 positivity, so 45% were negative for MON2, while 54% were positive. Now, the reason for all the patients not demonstrating the MON2 positivity, which I realized was due to limitation of the test due to improper technique of administering the tuberculin antigen, or the dose of tuberculin antigen which was administered was not adequate, or the reading of the test was not done by a trained personnel. Now, talking about aspirates, the nature of aspirates on fine needle aspiration cytology. So almost half of the patients, they were having the pus aspirate, and 40% were having the blood mix aspirate, and 4% they were having the cheesy aspirate. Now, according to cytomorphological findings, the different patterns which I told you initially, so around half of the patients, they presented with the most common pattern, that is the necrotizing granulomatous lymphadenitis, meaning there was granuloma as well as the necrosis. Nearly 1/4 of the patients, they presented with only granuloma without necrosis, and little less than this were showing only necrosis. Now, when we compared the AFB detection bacilli with the different methods like Zeal-Nielsen staining, auramine, rhodamine, autofluorescence, and culture on the blood mix aspirate, there were total 33 patients who were having the blood mix aspirate. So what we found out that out of the 33 patients with blood mix aspirate, the Zn staining was positive in 45%, auramine rhodamine in 51%, autofluorescence in 48%, and culture in 63%. So taking culture as the gold standard, the auramine rhodamine was found to be more sensitive, followed by autofluorescence, and the most specific was the Zn staining. Now, out of the 39 patients with pus aspirate on FNAC, Zn staining was positive in 58%, auramine rhodamine in 64%, autofluorescence in 66%, and culture in 74%. Now, sensitivity of auramine rhodamine staining and autofluorescence was found to be highest, while the specificity was still highest with the Zn staining. Now, there were only 3 cheesy patients with having cheesy aspirate, and the sensitivity and specificity of all the staining pattern, be it Zn staining, auramine rhodamine staining, autofluorescence staining, was same, and the specificity was also same with the cheesy aspirate. Now, in the patients with necrotizing lymphadenitis, first we compared the aspirates. Now we are comparing the cytomorphological patterns. So in 17 cases with the necrotizing lymphadenitis, the highest sensitivity was shown with the autofluorescence, followed by auramine rhodamine, followed by Zn staining. With the various methods with the granulomatous, now the cytomorphological pattern was granulomatous. Out of the 19 cases, the highest sensitivity was shown by autofluorescence, followed by auramine rhodamine and Zn staining. In case of necrotizing granulomatous lymphadenitis, which is the most common cytomorphological pattern, the auramine rhodamine was found to be more sensitive, followed by autofluorescence, followed by Zn staining, but still the specificity was highest with the Ziehl-Neelsen staining. Now, those patients who were positive for MON2, when the AFB detection was done in them, so again the sensitivity was highest with auramine rhodamine and autofluorescence. Those with negative MON2 test, the autofluorescence showed little higher as compared to Zn staining and auramine rhodamine stain. So what we found out from this study was that FNA has become the first line diagnostic technique that is highly sensitive, especially in endemic areas where the mere presence of epithelioid cell granuloma indicates tuberculosis until proven otherwise. Albeit it's not specific, as other opportunistic infections may present with the similar cytomorphological features. So we need to identify these acid-fast bacilli by doing the different staining patterns. We all know that cultivation of tubercle bacilli is the most sensitive method and is considered as the gold standard, but it takes weeks for the tubercle bacilli to grow on these media, and if we have to wait for such a long time, then it will not be good. It will not be in the favor of patients. So we want something which is quick, which is simple, and so that we can make a diagnosis easily, and we can start the treatment at an earliest possible time. Conventional Ziehl-Neelsen staining, which we are performing, is simple but demands technical proficiency in staining and experience in identification of organism. Moreover, it's quite tedious to just scan the slide for the acid-fast bacilli. The superiority of the fluorescence stains like auramine rhodomine for the diagnosis of tuberculosis has been well recognized in decreasing the runtime for sample examination, because as I told you earlier also that we need to examine them under the low power, and if they are present then we can just see them fluorescing or as the golden yellow bacilli. So the runtime is decreased. However, nothing comes without any with all the advantages. It has also disadvantage that these dyes are unstable and they use expensive fluorescence reagents. Moreover, these dyes being carcinogenic cause problems to the health workers who are employed in its usage. However, unlike the auramine rhodomine staining, autofluorescence method, they require just the pap stained smears, and thus no carcinogenic dyes are required. So that is in one sense better as compared to the auramine rhodomine stain. Now, but the problem lies with this fluorescent staining is that the high cost and the short half-life of the mercury vapor lamp has limited the availability of fluorescence microscopy and healthcare systems with constraints financial resources. The recent development of light-emitting diode provides a cheap and reliable light source. Thus, it was observed in my study that although fluorescence stains were found to be more sensitive, but when specificity was considered, which is an important factor to be taken into consideration, the conventional Zeal-Nielsen staining was found to be the most specific. So what I concluded, and I think you all will also agree, that this study found that sensitivity was auramine rhodomine was maximum, followed by autofluorescence and least with Zeal-Nielsen. However, specificity was found to be maximum with Zeal-Nielsen stain and least with autofluorescence. Our study showed only marginal difference in sensitivity between the fluorescence stains and conventional methods. Hence, no single staining method is sufficient for definite diagnosis. However, fluorescent stains, they definitely add as an adjunct to Zn stain and culture in definitive diagnosis of tubercular lymphadenitis. Now, the take-home message is that if we want to have early diagnosis of tubercular lymphadenitis, especially in the fine needle aspiration cytology samples, so in adjunct to the Zeal-Nielsen staining, if possible, we should also do the fluorescent stains like auramine rhodomine and autofluorescent using the pap stained smears, so that they can add to the diagnosis, and the diagnosis can be made at an early stage. Also, no single staining pattern is 100% diagnostic, so we have to take in consideration that we have to combine these different staining methods if we want to have a definitive diagnosis. Also, the presentation can be, the tuberculosis can present in any way, can present without any symptoms, just like lymph nodes, or can present with all the symptoms. So we have to broaden our knowledge that this is a deadly disease. We have to identify it early, and we have to make an early diagnosis so that the patients can be cured early and will not be able to transmit this disease to others. These are the references which I used while during my study. I would like to thank you all for the patient hearing, and if you have any questions, please, you can ask.
Thank you, Dr. Ritika, for a wonderful presentation. As we all are aware that tuberculosis is endemic in India, and Dr. Ritika has done an exhaustive study on this, and she has evaluated very nicely on the tuberculosis demography, and also she has enlightened us about the detection of the Mycobacteria bacilli by one of the superior techniques like autofluorescence technique, apart from the conventional methods. And she also had, through her study, conveyed to us that autofluorescence technique had provided the platform which picked up the bacilli sensitively, but always Zenon staining was more specific according to her study. And it was good to know that through her study, especially for the postgraduates and for the trainees, that autofluorescence techniques help us to visualize the Mycobacteria bacilli as bright yellow fluorescence rods. And in short, thank you, Dr. Ritika,